what other suggestions would you have as to people to assess their thyroid function? Is it the symptoms that they have is perhaps the best guide, or do you use other methods of assessment?
Yeah, so the symptoms they have are the best identifier. When cells don't get enough thyroid, there are very specific things that happen. To make the diagnosis is a clinical assessment of the patient, head to toe, looking at the hair, looking at the eyebrows, looking at the tongue, looking at the neck, for any thyroid swelling, touching the patient, feeling the temperature of the body, measuring the temperature of the body, looking at the heels of the feet, looking at evidence for fungal overgrowth, which happens when temperatures go down, listening to them for symptoms of depression, of fatigue, and all of these other things, that happen when thyroid levels go down. That's really the way to make the diagnosis.
So then if low thyroid function causes inflammation in the body, and inflammation in the body is one of the main causes we now recognize of heart disease, maybe that explains why you and I have 20 chickens and I eat 3 to 4 raw eggs a day. You told me that you have 4 to 6 eggs a day, yet... Eight eggs a day. You're far from obese. In fact, you have just about 0 body fat, and you're not dropping dead of heart disease. I'm nearly 50, and I'm not dropping dead of heart disease. How can that be if we're eating 4 to 8 eggs a day? Have we got it wrong about eggs and heart disease?
Early on, when researchers looked at arteries and they saw that they had cholesterol in them, they made the erroneous assumption that the cholesterol was the cause of the heart attacks. Well, we know that that's not true at all. And now as medical science has really looked at what actually causes myocardial infarctions, we have come to understand that hearts really don't attack and that it's not the dietary cholesterol that raises cholesterol. We find that, and Virchow saw this, when he initially looked at the first atheroscleromatous plaque under the microscope, he saw that it was inflammation, right? This infiltration of lymphocytic cells, right? This area was under attack by the immune system for some reason. And now investigators at Harvard and Stanford and so forth have shown that this, what we call heart disease, or vascular disease, it's not the clogging up of a drain pipe type situation that we used to think that it was, where you just then the method for eradicating that, it would seem to be just kind of a roto-rooter type procedure to get the artery cleaned out. That's not how arteries build up with plaque. Arteries build up with plaque on the other side of the lumen, away from where the blood flows. So on the other side of the wall of the lumen, the intima of the artery, kind of on the inside, something happens. And that's where this inflammatory process happens, and the immune cells go from the lumen into, again, this middle wall, and they're attacking something, and that attack is really what inflammation is. Now, as that progresses, then you start to develop a bulge that can push into the lumen of the artery, and that's what the cardiologist sees when he goes up into your arteries with the catheterization needle to look at things. Now, that, however, that blockage that they tell you that you have, that doesn't so much predict whether you're going to have an infarct. What really determines whether you're going to have an infarct is how active that war is on the inside of your blood vessels there. So you can have a 90% blockage and never have a problem if the inflammatory process is over. You can have a 10% blockage and drop dead out of the cardiologist's office the next day if that plaque ruptures. So how active that plaque is as far as inflammation, that is what determines mortality. So when that plaque ruptures, as soon as it ruptures, then a clot forms. And that clot formation, that is actually what gives the people the so-called heart attack, because after that heart is deprived of oxygen, of course, being an emergency room physician, I saw this a lot, the heart then goes into a fatal rhythm that we call ventricular fibrillation, and that's what actually kills people.
So what's the cholesterol actually doing there? Why do we see cholesterol in the artery?
So cholesterol gets there. So there is and we've come up with this term good and bad cholesterol, which is also misnomers. There is oxidized cholesterol and unoxidized cholesterol. So normally when cholesterol is produced in the liver, it's used as a building block. Every cell in your body has cholesterol as a building block in the cell membrane, and particularly these cells that are in the brain and in the nervous system. Cholesterol is a very important building block for the nervous system. When cholesterol gets oxidized, and by oxidized, we basically mean that a similar thing can happen to cholesterol, or these proteins that carry cholesterol, the LDL, that happens to a nail, right? So you can have a nice shiny nail, when it comes out of the box. If you leave it out in the rain and it gets exposed to wind and so forth, then it'll turn rusty, right? That is the oxidation process. We've seen the same thing happen to paint on a house, right? It gets oxidized. When cholesterol gets oxidized and it's not really usable, and the HDL, which is the transporter that takes it back to the liver, it's not worth using anymore. So it doesn't get picked up and taken back to the liver by the HDL transporter anymore, and it gets left there. And while we're talking about this, let's just make that definition about what cholesterol is and what cholesterol transporters are. When we talk about measuring cholesterol levels and good cholesterol and bad cholesterol, we're not actually talking about cholesterol, we're talking about cholesterol transporters. So LDL and HDL are actually transporters, what I call the cholesterol trucks. So in the liver, the LDL, or the outbound truck, is loaded up with cholesterol. It takes it to all these outlying areas to be used as a building block for all these cells. Whatever's left over, then the HDL truck will load up and bring back to the liver for recycling. So we're actually talking about two proteins, right, LDL and HDL proteins, which are carriers rather than actually cholesterol.
So is what you're really saying that the cholesterol goes to the artery initially as part of the repair process of the inflammation, and then because nobody's done anything about the underlying inflammatory causes, the cholesterol starts getting oxidized itself. It's like, say that you and I are standing beside a road and we see a car accident and we run out on the road to help, and somebody takes a picture and says that you and I caused a car accident. That's not actually correct. You have I gone out there to help and not actually cause the accident at all. Of course, if we're standing out on the road then in the accident, another truck comes along and then we are involved. But originally we've gone there to help repair the underlying inflammation. Would that be a fair summary of what you've just said for us?
Yes, that's an excellent analogy.
All right. Okay. Well, that's been very enlightening for all of us. Thank you so much for giving us your spare time on a Saturday night in Amarillo, Texas. And thank you for all you do with your medical education and the posting of your great photos of the many great sites in Texas that we love to see. And hopefully we can do this again at some stage in the future.
Anytime, Greg. Just give me a call.
Thank you very much.
All right.